good questions, actually. Okay. So, last day of new material for this class. Let me share my screen. Boom. Okay. All right, everybody. Hopefully you can see the Chapter 4, Spine and Thorax. We are going back to Chapter 4. And today we're mainly going to talk about something called the spinal erectors, or the erector spinae group. And they're these muscles that run up and down the spine. But before we get to them, I kind of want to give you an overview of the back muscles because there is a lot. So let me say that again. We're going to talk really just about 3 muscles today. But before we get to them, I want to give you an overview of coming attractions. So the overview I wouldn't get too caught up in. We're going to talk about everything in the overview individually. The only thing individually we're going to talk about today is these 3 erector spinae muscles. But again, I want to give you kind of the landscape because I want you to see how complex essentially the back is. But the spine and thoracic region. And the spine and thoracic region are very complex because it is quite a feat. It is quite a feat to balance 24 dominoes on top of themselves and have them articulate and move around and do all the things they do so that you can function and not have it all fall apart. I mean, just think about it. Your vertebra really are these kind of dominoes stacked up like this. There's not any support for them down here in the skeletal support for them down here in the low back. And you are able to do all sorts of crazy things with your thoracic region and make it all work and lift really heavy things too. That's the other really amazing thing, that you can coordinate all this strength through the arms and somehow channel it down here through the low back down to your legs. It's quite amazing. Quite amazing. Okay. Please feel free to ask questions. So, we've already kind of studied some muscles that are found on the back. We don't really think of them as back muscles because we think of them as shoulder girdle muscles, and that's true. We've studied so far muscles that move the shoulder and arm, right? Muscles that move the shoulder and arm. Those muscles are found on my back and chest, but those are the muscles we've studied. And those are superficial muscles. The muscles we're going to now, we're going to have to actually tear those muscles off to find these deeper muscles. So I want you to start thinking in terms of layers, which we don't have to think of in normal life. Normal life, I'm really going from here to there. I don't have to worry about what's under the ground. But you guys work under the ground. So you don't just care about the highway from Phoenix to Flagstaff, you care about the mineral rights underneath there and all these layers underneath there because you work down. And that's important. There's different stuff at different layers in the body. So, what we studied first was a really big triangular diamond-shaped muscle on the body here that actually kind of hung off the middle portion of the superior nuchal line, the external occipital protuberance, the ligamentum nuchae, all the way down these spinous processes down to T12. That was its origin, and then it fanned out on both sides and inserted into the lateral 1/3 of the clavicle, the acromion process, and the spine of the scapula. Miss Felix Osuna, what muscle is that I just described?
The traps.
The traps! Thank you, Miss Felix Osuna. Awesome. Yeah. Cool. And what type of actions can the traps produce, Miss Harper? What type of things can the traps do, Miss Harper?
It can elevate.
Yes. Elevate the what?
elevate the scapula?
Yes, that was exactly right. It's not really it's the scapula. It can lift up the scapula, elevate the scapula. Yes. What else can it do?
It can also depress.
Depress the scapula. Upper fibers can elevate, lower fibers can depress the scapula. What else can it do?
Medially rotate. Medially.
Can't rotate because it doesn't attach to my arms.
Yeah, it can. So, no. It can protract.
How about retract?
No, retract.
It can retract and adduct. The middle fibers can retract and adduct my scapula, which is what I was doing right here. So elevate, depress, retract or adduct. Cool. Is there anything else that it can do, not to my scapula, but to my head?
It can flex.
How does it flex my head? Is it in front of me and pulling it down?
Oh, it can extend.
Oh, extend. Yeah, because it's behind me. Okay, extend. Yeah, and is there anything else it can do? I'm not saying no.
It can rotate
It can rotate my head too. If it's working unilaterally, it can rotate my head. I don't worry about which side does what, but it can unilaterally rotate my head. That's a lot. Thank you. That was a lot. Thank you. So we studied the traps, and then we studied a muscle that actually shares its origin is the insertion of the trap. So its origin, this other muscle, is the lateral 1/3 of the clavicle, the acromion process, and the spine of the scapula, and it kind of comes down the arm here in kind of an upside down triangle and inserts into the deltoid tuberosity of the humerus. And what muscle is that, Miss Bolotic?
The deltoid?
Yes, it is the deltoid. Awesome, thank you. And Mr. Kondaris, what actions can the deltoid perform? What things can it do?
It can abduct.
Yeah, thank you. That should probably be the number one answer, right? It can abduct my arm. It can pull my arm up like this. Thank you. It can abduct the glenohumeral joint because it's actually attached to the shoulder. Abduct, cool. What else can it do?
Adduct. It can come back down.
Not really.
But what goes up must come down.
That's true, but my deltoid is not underneath here. It can't pull my arm down. It's above. It can pull it up.
Okay.
You know what brings my arm down in this case?
Your lat.
Well, in this case, it was gravity, but yes, my lat would have been an excellent answer too. Thank you. My lat, yes.
Okay.
So you kind of described the middle fibers. What do you suppose the rear fibers can do?
Extend.
Yes, excellent answer. Thank you, sir. What do you suppose the front fibers can do?
Flex.
Yes, yeah. And there's just one more thing. These guys, the front fibers are diagonal. So is there anything else they can do?
They can medially and laterally rotate.
Yeah, actually, you're right. Front fibers medially rotate. Back fibers laterally rotate. Thank you. Thank you, thank you, thank you. That was really good. Okay, so we talked about the trapezius and the deltoids. They often work together, right? Because as I raise my arm out, my scapula also rotates up, which is, by the way, one of the actions that I forgot to describe too, that the traps can help with. But anyway, all this can kind of work together. Cool. Awesome. We discussed that if we tore those muscles off, if we tore off the deltoids, and we tore off the traps, then underneath them, we would see this kind of Christmas tree kind of thing back here. Like a two-part muscle that looks kind of like a Christmas tree, 4 fingers and 2 fingers, attached to the medial border of the scapula, kind of from the inferior angle of the scapula, kind of up to the spine of the scapula, and going over here to the spinous processes of C7 and T1, and then T2, T3, T4, T5. These 6 spinous processes kind of running diagonal. Right up there, yeah. And what is that muscle, Miss Petrie, that looks like that? Or muscles in a way. Two muscles with kind of the same name, kind of.
Are you talking about the teres major and minor?
Nope, they'd be over here. I'm talking about this muscle that runs between the medial border of the scapula and the spine of the scapula, and it looks kind of like this. There's a smaller one on top of the other one. They've got a similar name. One's 4 fingers wide, one's 2 fingers wide. One's kind of a major, big deal, and the other one's kind of a minor deal.
Isn't that the rhomboid?
Rhomboids major and minor, yes. Thank you, ma'am. Rhomboids major and minor. Awesome. And what are their actions, Miss Monreal? What are their actions of the rhomboids major and minor?
To retract the scapula.
Number one, absolutely to retract the scapula, or to, what's another word for retract the scapula?
Hold on.
You're doing, you got it.
Meat. No, I'm sorry.
Meat?
I'm totally not.
No, meat is like you got the right feeling of the right answer right now. You just have to add that feeling together to get the right, solution.
What is it? Medial flexion or?
No, just add that feeling.
Oh wait,
together.
wait, I'm so sorry. Medial adduction.
Just adduction. Adduction.
Whatever. Okay.
You're trying to think about rotations and stuff. Yeah, adducts. They get closer to the spine at adducts. Is there anything else that the rhomboids can be responsible for? Remember, they run diagonal.
Does it in elevating the scapula?
Yeah, they can also elevate because they can pull up. And because they're pulling from the bottom, they can cause the scapula to kind of turn down actually a little bit too. And we call that a downward rotation. Really good. All right, good stuff. So that was rhomboids major and minor.
Wait, so recapping, what was the word we just said? To bring it back in?
So recapping, let me recap the whole thing.
Okay.
Recapping, we've got this, really it's one muscle, two names, whatever, rhomboids major and minor. One's about 4 finger widths wide, the other one's 2. One attaches to 4 spinous process, the other one attaches to 2. And they run from kind of the inferior angle of the scapula up here to the spine of the scapula on the medial border here. And they go over to C7 to T5, these spinous processes, and they look kind of like a Christmas tree there. And because of that angle, they can retract, or adduct the scapula, either pull it back or pull it to the spine, retract or adduct the scapula. Because they're going diagonal, they can also elevate the scapula. And because they're going at an angle too, when they pull, they can also downward rotate the scapula a little bit. Was that a good summation? Okay. You were just holding your face like I hurt you. You can be tired. I'm just playing with you. Okay. So, believe me, I know how you feel by Thursday. It's, yeah. And I wasn't at the hospital with somebody, so. Then we've got another muscle that's also on the medial border. You're going to kind of notice I like to kind of follow certain themes, right? I talked about the traps and the delts because they work together. Now we're kind of we ripped those off, and now we're talking about the rhomboids major, rhomboids minor. And then there's another muscle that's kind of between the spine of the scapula and the superior angle of scapula on the medial border, and it hooks into the transverse processes of C1, C2, C3, C4. Yeah, and it looks kind of diagonal like this. And what is that muscle, Miss Hansen?
Levator scapula.
Levator scapula. And what do you suppose the levator scapula could do?
Elevates the scapula.
Yeah, 100%. Definitely elevates the scapula. Definitely elevates the scapula. Could it do anything to the head and neck?
Rotate it.
Yeah, we believe it can help rotate the neck. It probably caused some lateral flexion too, right? Pull it over, yeah. Yeah, I don't even know if your book says that, but I would just assume lateral flexion. Some rotation, some lateral flexion. Good. These are exactly the type of thinking I want, exactly the type of answers I want, and they're exactly correct. Thank you. That's awesome. And the levator scapula causes lots of people lots of problems. It's a tiny muscle, and it weaves kind of right by all these nerve plexes from the neck, right? Those nerve plexes from the neck that feed another part of the body. By the way, Miss Cooper, what part of the body do the nerve plexes of the neck feed? The neck.
It's your arm.
You're darn tootin', it's my arm. Excellent answer. Thank you very much. Yeah. The neck feeds the arm. So this kind of forms into what we call the brachial plexus. In fact, I just had a student in my continuing ed class yesterday who had some surgery, and they damaged the brachial plexus, and she couldn't use her bicep because the nerve that feeds her.
You remember what I was saying about how, like, you might have an arm issue if you have a neck issue, etc.?
Yes.
Isn't that why?
Yes.
That's why? Yeah.
So in her case, her bicep is fine. She doesn't have an arm issue. She's got a neck issue, and it's killing the wire that goes to her bicep, and she literally can't flex her bicep. She could still use her hands. She could still do all sorts of stuff. She can't use her bicep. Kind of interesting. Yeah. Now, even though she couldn't use her bicep brachii, Miss Yanez, even though she couldn't do that, and the biceps brachii, really its main job is to flex the elbow, right? To flex the humeral ulnar joint. By the way, the bicep does cross over the shoulder, so it can also flex my shoulder, but its main job is to flex my elbow. Was she still able, even though she didn't have control of her biceps brachii, was she still able to flex her arm? If she had control of everything else?
Yeah.
Yes is right. The question is, do you know why it's right? Is there another muscle that would let her flex her arm that we've learned about? And I hate to tell you, it's not going to be in chapter 2, which is probably where you're looking right now. But it'll be in your notes, maybe. Is there a muscle underneath the biceps brachii that allows you to do a flexion of your arm and actually makes up for most of the size of the front of your arm? Anybody?
Well, doesn't your
Brachialis.
Brachialis. Yeah. So underneath your bicep is the brachialis under here too. By the way, what I am doing today is extremely difficult. Right? Before we've been giving you very spoon-fed information. Now I'm asking you to take that information and mix it around and answer it out of the blue. So it's extremely difficult. Awesome. So that's the biceps brachii and the brachialis. Cool. Awesome. So we talked about the rhomboids major, rhomboids minor, levator scapula. Remember, we've already ripped off the trapezius, we've ripped off the delts, and so underneath that, once you rip off the delts and the trapezius, you can see the scapula here, but there's muscles on the actual scapula that hook over to the humerus, right? There's a group of 4 of them. There's a group of 4 very prominent muscles that are on the scapula and go over to the humerus and help stabilize it. They do lots of other stuff, but they help stabilize it, these muscles, this group of 4. What do you suppose that group of 4 muscles is called? Miss Nguyen, what is the group of 4 muscles? You didn't even have to give me their names. I just meant, like, what do we call this group of 4 muscles that helps to stabilize this thing, helps to rotate it?
I think in
Infraspinate, what? Yeah, I think you're trying to say infraspinatus.
Yeah.
Okay, you're actually correct. That's one of them. The whole group is just called the rotator cuff muscles. The question is very confusing. I apologize. But you are right. You are right. The one down here is called infraspinatus. So, Miss Nguyen,
Yeah.
if this down here, if this is infraspinatus, what's the one on top called? You're doing great. Yes, you are correct. Supra,
Super
spine,
spinal.
atus.
Aiders.
Perfect. I love that. Okay, so we got the supraspinatus, infraspinatus. Anytime I say infraspinatus, you should also say, there's another muscle we always associate with infraspinatus. So supraspinatus, infraspinatus, and teres.
Minor.
Teres minor, cool. And then underneath we've got,
The subscapular.
yes,
Suprascapular.
subscapularis.
Yeah.
Sub, scap,
Subscapular.
you,
You.
laris.
Right.
Man, I feel for you. These words are hard. You're doing great. Thank you. And
Yeah.
by the way, Miss Nguyen, you knew the right answer. That was really good. Yeah, good job.
By
Cool.
doing that, it's helping me too. So I'm over here repeating it all the time. So it's not just for her.
Yeah.
It helps me too a lot.
Yeah, I wasn't just trying to make you feel better, Miss Nguyen. Like, everybody has a hard time pronouncing these words. And when I break them down for you, even I have to think about it. If I went around and asked everybody to say them, you'd find out they have a really, it's challenging. They're hard. Right? None of us are speaking English right now. These are Latin and Greek words and such. So, yeah, it's new. It's all new. Okay, so we ripped off the traps, we ripped off the delts, we looked at the rhomboids major and minor and the levator scapula, we looked at the rotator cuff muscles, the supraspinatus, the infraspinatus, the teres minor, the subscapularis. We talked about the biceps brachii and the brachialis underneath it in front. In back of my arm, I have a three-headed muscle that's main job, well, I won't even say its main job. In the back of my arm, on the posterior side of my arm, I only have one muscle. And it's a three-headed muscle. And what's it called, Miss Stanley?
Triceps brachii.
Yes. I was about to give you all those clues, but you did great. What does tri mean?
3
What does seps mean?
heads.
Yes. And what does brachii mean?
The arm.
Arm. And I said a three-headed muscle on the back of the arm, and you said a three-headed arm muscle. Triceps brachii. That is absolutely correct.
Yeah, the 3 was like, I was like,
Yeah.
because you said 3 and I was like,
It's
trying
the
to remember.
only three-headed muscle I can think of. That doesn't mean there aren't some small ones somewhere, but triceps brachii. Very good. So what is the main action of the, actually, yeah, there's a couple actions, but what is the main action of the triceps brachii, Miss Hunter?
Okay, triceps. What do they do? Do they adduct the arm?
Well, now, the tricep essentially runs to the elbow, which is actually part of my forearm, runs to the elbow and runs back here.
Right.
So it does cross over the shoulder, and there is, the long head does cross over, and this part's complicated. The long head does cross over and attach into the scapula and can help with an adduction or an extension of the arm. It can help. But its main job is to pull on my elbow. What do we call it when this happens?
That is. Oh God, I want it to be extension, but is it not? Oh.
What do you think? Do you want to go with extension, or do you want to change it to medial rotation with a horizontal abduction, elevation, protraction, inversion,
I get
supination?
confused because it looks like extension, but it's in front of you, so then I don't know if it's flexion or extension. But it extends the elbow?
Yes, you're 100% correct.
Okay.
I just wanted you to commit. Sorry. Yeah, it doesn't matter. I understand it's in front of me, but where's the arm moving?
Right.
Back.
Yeah.
Back.
Yeah.
By the way, this is an extension too of my shoulder. Doesn't matter that my arm's in front of me, it's heading back.
Okay.
Yeah. So by the way, this is me extending my elbow. This is me extending my elbow. This is me extending my elbow. The elbow is still doing the same thing.
Got it.
Fun tricep fact. Any of you lift weights? Maybe? So, when you do like tricep pushdowns, where you got like a cable here and you're pushing down like this, you're not working all three of the heads of your tricep because the long head is kind of loose in that position. That's why you'll sometimes see people hold a dumbbell above their head like this and lift it like this, because the long head is also stretched in this position, so they're getting all three heads working at once. Yeah, these are things personal trainers learn and stuff. You would easily be able to pass a personal trainer test after this class. All the muscle questions and such. Very cool. Okay. So if we tear off all these muscles, then we start to get to some very interesting muscles. We start to get to these neck muscles that are deep underneath here, called like the semispinalis capitis and splenius capitis and splenius cervicis. They're all under here. We start to get to some muscles that are called erector spinae muscles that we're going to talk about today. By the way, there are muscles below the erector spinae muscles too. It takes a lot of muscles in your back to make it work. So I just want to make sure we had some footing. So this picture here on the right-hand side outlines some of the muscles that we're going to be looking at. We're going to be looking at these long muscles that come up the back. Let me take you to a better picture. Later we will learn about, if you rip those off, about rotatorius and multifidi. Those are the shoelace muscles underneath, but those are even deeper, and we're not going there yet. And some occipitals. Let's not worry about any of this yet. Okay, let's go back. Okay, so we're going to be talking about the erector spinae group. So we've ripped all this stuff away, and now we're looking at these like things that look like a tree, like a long tree kind of climbing up the back. Your book says they kind of look like a popular tree. And by the way, they're on both sides of the back. They're only showing you half the back. Now, let me explain something about this. This group is called the erector spinae group, and it's got three muscles that make up the erector spinae group: the spinalis, longissimus, and iliocostalis. Let's stop right there for a second. So, Miss Cooper, this group is called the erector spinae group. What is this group called?
What, the erector spinae group?
Thank you. It's made up of the spinalis, longissimus, and iliocostalis. What is it made up of?
Spinalis, longissimus, and iliocostalis.
Good. Thank you. That's all I wanted to hear. Thank you. Mr. Kandaris, this group is called the erector spinae group. What is this group called?
The erector spinae group.
Thank you, sir. It's made up of the spinalis, longissimus, and iliocostalis. What makes up this group?
The erector spinae group.
Yes, what makes it up? What three muscles are in it?
Oh, the longissimus, iliocostalis, and the spinalis.
Thank you, sir.
Oh, yeah.
That's fine. That's absolutely fine. Thank you. Miss Harper, this group is called the erector spinae group. What is this group called?
It is called erector spinae group.
Thank you. It's made up of the spinalis, longissimus, and iliocostalis.
Okay.
What three muscles make it up?
It's made of spinalis, longissimus, and iliocostalis.
That was beautiful. Thank you. Yeah. Miss Nguyen, this group is called the erector, say erector,
Rector.
spinae,
Spinae,
spin,
spin,
a,
a,
spinae.
spinae.
Boom. Group. Cool. Now we're going to say the muscles in that group: spine,
Spy,
Alice.
Alice.
Spinalis.
Spy, Alice.
Beautiful. Long.
Long
Is.
is
Imus.
shimmer.
Longissimus.
Long is shimmer.
Beautiful. Ilio. That's hard. We might have to break that one down. It's okay. Il.
L
E.
E
O.
O
Ileo.
Elio.
Beautiful. Coast.
Cost
Alice.
Alice.
Costalis.
Cost Alice.
Ilio costalis.
Elio. Cost Alice.
That was beautiful. Awesome. Stop right there. Cool. All right.
Thank you, sir.
Thank you. Thank you. You're very brave. Miss Torres.
Yes.
Miss Torres, what's the name of the group that we're studying right now?
Erectors spine group.
Thank you. And what three muscles make up this group?
Iliocostalis, longissimus, and spinalis.
Yeah. Yeah. Thank you.
Spinalis?
Yeah, spinalis. That's beautiful. Beautiful, beautiful, beautiful. Cool. All right. The fact that this group is called the erector spinae group is because it keeps you erect. It's meant to pull my spine back and keep me erect. Yeah. So what do you guys suppose is the main action of these muscles? Anybody?
Extension of the back.
Yep, extension of the spine. Beautiful. Extension of the spine. Yep. Yep. And if it were to work unilaterally, extension of the spine is bilaterally. If it were to work unilaterally, what do you suppose might happen?
Lateral extension.
Lateral flexion. But yeah, but you got the right idea. Lateral flexion. Yep. Lateral flexion to the right or the left, depending on which side it's working. Lateral flexion to the same side that's working. Cool. Well done, everybody. Okay. So here's the deal about spinalis, longissimus, and iliocostalis. All three are actually made up of a whole bunch of little muscles. And don't worry, we're not going to learn little muscles. They are the same muscle. So here's what I mean by that. This isn't going to really look like it, but let's say this is a spine. Those are your vertebrae, okay? By the way, there's the little spinous processes. The spinalis essentially hooks to the spinous processes. That's what it does. Well, really it goes like this. It's actually made up of a whole bunch of little muscles. But can you see that after I do this for a while, it starts to look like one muscle because they're all doing the same thing. And so just for convenience, we call this muscle the spinalis. And I'm going to tell you a tiny piece of information that you can almost throw out as soon as I tell you. I just want to tell you in case you ever run across this in a book. Some people get really nitpicky. And they say, well, the spinalis up here in the cervical region is the cervical spinalis. The spinalis here in the thoracic region is the thoracic spinalis. And the spinalis down here in the lumbar region is the lumbar spinalis. That's them getting really nitpicky about talking about it. I don't give a damn. It's all the same muscle. It's all connected. And yes, your body can fire it in different ways and stuff, but they're just trying to make it even more confusing than it needs to be. It's a whole bunch of little muscles that follow a pattern. And they hook onto the spinous processes of your back. We're going to get more detailed than that, but that's why they call it the spinalis, because it hooks to the spinal processes, and it covers essentially the whole back. Essentially all three of these muscles cover the whole back. There are some exceptions I'll explain here, but essentially they run up and down the back. The spinalis is closest to the spine. It's hooked to the spinous processes. The spinalis is hooked to the spinous processes and is closest to the spine. Miss Hunter, what is the spinalis hooked to? Did you hear me, Miss Hunter? No? Sorry. What is the spinalis hooked to? What is it attached to?
Spinalis. Are you talking about a bony landmark?
Yeah.
Okay. Oh, those pointy thingies.
Yeah.
Hold on. I don't know what the name of it is.
It's these processes that come out of the spine.
Oh, spinous process.
Oh, that's a good name for them. I like that. So yeah, it hooks it like the spinalis likes to hook to the spinous processes. And of the three muscles, which one is closest to the spine?
I'm sorry, what was the question?
Well, we've got these three muscles that we're learning about, the spinalis, longissimus, and iliocostalis. And they kind of, they run, they can't all be. Which one is closest to the spine of those three muscles?
The spinalis?
Oh my gosh, that's so convenient. So they call it, are you telling me they call it spinalis? It hooks to spinous processes and it's closest to the spine?
Yes, sir.
Thank you. Thank you. Everybody, Ms. Hunter has stumbled across a very useful piece of information. The spinalis is called the spinalis because it hooks to the spinous processes and thus it is closest to the spine. Cool. I love that. Awesome, awesome, awesome. Miss Hanson, what is the name of the spinal erector muscle that is closest to the spine?
Spinalis.
Yeah, what is it attached to?
The spinous process.
Yeah, thank you so much. That's awesome. Yeah, cool. Miss Petrie, what is the name of the erector spinae muscle that's closest to the spine?
The spinalis.
Yeah, what is it attached to?
It attaches to the spinous processes.
Thank you. Of the vertebrae. Awesome. Beautiful. Perfect. Cool. Okay. So let's go out from this one. As we were. Please ask a question. Yes, sir.
So I was thinking when there's the spinalis, you said those connect to each process, right?
Yes. I'm going to get more detailed in a minute, but yes, that is true.
Well, I was just thinking about the multifidae.
Yeah.
And so are they just like right next to each other, or are they like just they also go up the spine? That's why I was curious.
Yes. No, you're good to ask, sir. The multifidi, and it could be multifidi, whatever, however you said it. The multifidi and rotatories are actually underneath, even deeper than this muscle. And so later we will rip this muscle off and go even deeper.
Okay, cool.
So
Curious.
So everybody, look at this for a second. This is just 2 vertebrae. You've got 24, right? But if I attach a muscle from here to here and they pull, can you see that what happens is this starts to extend? That's how I do an extension. That's how the spinalis helps me. If these pull together, it closes here and back, but it opens in front. Well, this is how my spine is right here. And this is me. This is what happens when I do this at 24 joints. So if this thing just, let me get this. If this thing just goes up just a little bit, if this goes down, this goes up. If that happens at 24 joints, this is what happens.
Retract,
Extend.
extend.
Yeah, but I like that you said retract because you're thinking backwards, and that's good. But it's extend. This is an extension of my spine. Really what it is 24 extensions of my vertebrae. But what I'm trying to say is these big things here, these spinous processes, are meant to be levers for muscles to grab onto to pull my spine back. That's their point. That's their purpose. And that's why in your lumbar region, the levers are even bigger because there's even more to pull back there. So that's the spinalis. It attaches to the spinous processes. Yeah? Then we've got the longest spinal erector muscle there is. The longest spinal erector muscle actually attaches, believe it or not, to your head. and basically runs down to your bottom, basically. And by the way, it too is made up of all sorts of little ones. But after you do this for a while, it starts to look like one muscle. And it is, you know, for all purposes, it's one muscle, right? And this muscle I'm about to talk about is the longest muscle of the erector spinae group. So Miss Bolotic, what do you guess? I haven't told you yet, but what do you guess is the longest muscle of the spinae group, of the spinal erector group?
The longest.
Brilliant! Brilliant. Yes, the longissimus is actually named longissimus because it is the longest muscle of the spinal erector group. It is more lateral than the spinalis, but it is not the most lateral. The most lateral is a muscle that hooks to the crest of your ilium, which is your hip, the crest of your ilium, and sews into your ribs or your costals. What do you suppose we should call that muscle, Miss Yanez?
The iliocostalis.
Yeah, she just said the hip rib muscle. The ilium is the hips and costals are your ribs. She just said the hip rib muscle, and that is the most lateral. So, if I'm working on a human body, most lateral iliocostalis, then longissimus, and then spinalis, kind of in the middle, kind of. Cool? Yay, it's so cool. Miss Torres,
Yes.
what is the most lateral spinal erector muscle? Erector spinae muscle.
Is it spinalis?
So your spinalis is out here most laterally?
No.
Oh,
It's iliocostalis.
yes. Iliocostalis is most lateral. What's most medial?
The longissimus.
The longissimus is right down in the middle. And then where's the spinalis?
There. Like more to the medium.
Oh,
Medial?
so it's more medial than the longissimus? Well, wouldn't that make it the most medial?
Yeah.
Okay, so are you saying the most medial is the spinalis?
Yes.
Oh, okay, so the most lateral is the iliocostalis and the most medial is the spinalis.
Yes.
That kind of makes sense because the spine is right in the middle. It's the most middle part of my body, so the spine itself is the most medial, and so the spinalis attaches to the spinous processes, so that makes sense. Thank you. Thanks for clearing that up for me. So, spinalis, longissimus, iliocostalis. Cool. On a back, spinalis, longissimus, iliocostalis. Cool. I love that. Thank you, ma'am. Miss Stanley. What is the most medial erector spinae muscle? Yes. What is the one next out from that? Next out laterally, not the furthest out laterally, the next out laterally from that.
Longissimus.
Yes. And what is the most out laterally?
Iliocostalis.
Yes. Very well done. Yep. Good job, everybody. These are hard. By the way, I hope none of you feel like I'm making fun of you. I'm just trying to lead you through like a process of thinking about all this. And laugh along the way. Cool. All right. Let's talk about them a little bit more. Okay. So, as an entire group, by the way, the picture you are looking at now on my slide, which is, I think, page 197 in your book, is very confusing. I do not like what they've done at all. They've shown you half of the spinalis. So they took these things up here. They showed you half of the cervical part, and then they switched sides and showed you half of the thoracic and lumbar part. But the muscle actually looks like, if they should have shown you both sides, because this is what the muscle looks like. So they showed you the right side of the neck and the left side of the thoracic region and lumbar region. Does that make sense? I don't like that they did it. I'm just trying to explain to you. It's a very deceptive picture. They're trying to show you the difference between the spinalis cervicis and the spinalis thoracis, and we don't care. It's all one big long muscle that extends my neck, extends my thoracic region, extends my lumbar region. It extends the spine. And if you look at what the group does, the group bilaterally, if it's working together bilaterally, it extends my spine. If it's working unilaterally, it does lateral flexions for me. That's all. That's it. That's what the group does. And as I recall, that's what each individual muscle in the group does. So they're not confusing in that sense. Remember, I like the ponytail analogy? Well, these are basically ponytails that run all the way down to your butt. Cool. And you guys feel these muscles all the time. They kind of create the, have you ever seen somebody that looks kind of like they've kind of got ropes going down their back a little bit and the spine is sunken in a little bit? You're looking at their spinal erectors. You're looking at their spinal erectors, especially the spinalis and longissimus. Now, your book makes the origins and insertions extremely confusing for these muscles, and it doesn't have to be. I've put a handout in today's lecture that you can download that goes over all of the muscles of the spine and thorax and puts them into a simpler format. And it talks about the erector spinae group muscles in a simpler format. So let me explain. Bear with me because this is worth doing to make your lives simpler in the long run, okay? So we've got our skeleton here, right? Mr. Skeleton here. Let me make sure that Mr. Skeleton is where he should be. Let's do this. Okay, better. Good. Like it. Okay. So, Mr. Skeleton here. Who can read me the origin for the spinalis? Right out of your book or right off this slide.
I can.
Okay, cool. What is it?
Spinous processes of the upper lumbar and lower thoracic vertebrae, and the ligamentum nuchae spinous process of C7.
Cool. So it is claiming these are origins right here. It doesn't even get really picky about which, but right in here. And can you go ahead and read me the insertions?
The spinous processes of the upper thoracic and the spinous processes of the cervicals.
Okay. So it's saying the origins are here and the insertions are here. Oh, I don't even know how to explain this. I just feel like they've destroyed it. Okay. When this muscle contracts between here, in this case the spinalis, you can't argue whether really this vertebrae comes closer to this vertebrae or this vertebrae comes closer to the other one. They both come close to each other. When I'm doing an extension, my vertebrae are just coming close to each other. By the way, I can also lift up my back leg and bend my back, and then it's coming up this way. So it's very hard to talk about origins and insertions. And I feel like they very arbitrarily picked origins and insertions. In fact, it's very weird that some of the insertions are found in the thoracic area, the area that doesn't move so much. That should really be an insertion. So I don't even like thinking about origins and insertions when it comes to the erector spinae group. I like thinking about attachments. Just attachments. An attachment can be an origin or an insertion. I actually pretty much do this for the entire body. I think in terms of attachments. That's why I don't mind if you mix up your origins and insertions. I don't care. You got the two spots that the muscle's going on. I don't mind if you say I took I-17 from Flagstaff to Phoenix or I-17 from Phoenix to Flagstaff, we're talking about the same road. Does that make sense? So I don't care about beginnings and endings. I care about endpoints. And those are attachments. And if we took all this confusing baloney they just told you, what they said was the spinalis attaches to the spinous processes of C2 to about L3, roughly. That's what they said. Now, they talked about the ligamentum nuchae, which is right in here too. The ligamentum nuchae, believe it or not, is attached to all the spinous processes in here. So saying ligamentum nuchae to me is the same thing as saying you attach the spinous processes. The only spinous process it didn't attach to up here is C1. Why did it not attach to the spinous process of C1? Anybody?
It doesn't have one.
Thank you. It does not have one, Miss Torres. It does not have a spinous process, so it can't attach there. But it can attach to the ligamentum nuchae, which attached them back then. So, boom. And it looks kind of like this. There. Can we see that? That red thing is your spinalis. Now, here's the part that's a little bit deceptive. As a massage therapist, I think about this going all the way down here, because what's down here? What's the big aponeuroses down here?
It's the lumbar region that holds the hip area, which would be like the iliac tract and the sacrum.
Yes. You are 100% right. What's the aponeuroses that's in the thoracic region and the lumbar region called? Or the fascia or whatever.
The thoracolumbar aponeurosis.
Yes. But you're right. By the way, you're 100% right. Thoracolumbar aponeuroses. And you're right, Miss Petrie. It's this area down here. And that thoracolumbar aponeuroses, by the way, everybody, is like a big sheet of tendon that kind of hooks through here. And it kind of sews all this back. I'm representing it with green here. But in a way, we don't know what happens to this muscle because it disappears into the thoracolumbar aponeuroses, and the thoracolumbar aponeuroses hooks all the way down into your sacrum and your lower lumbar. So I consider the spinalis to go all the way down to your butt, basically. Technically speaking, it attaches to the spinous processes of C2 to L3. Technically, it attaches. I don't care about origin insertions. It attaches to these, and when you pull them, the spine bends back, right? But it goes all the way down to the thoracolumbar aponeuroses and just kind of weaves in there. That's why we work this area so much. There's a lot of tension on it. Yeah. So that's the spinalis. Let's look at what your book says about the longissimus. Anybody want to read the origins of the longissimus to me?
Yes.
Thank you.
Origin, common tendon, I guess thoracis.
Yeah.
Transverse processes of upper 5 thoracic vertebrae, cervixus and capitis.
Yeah. read the insertions for me if you don't mind.
Sure. Lower 9 ribs and transverse processes of thoracic vertebrae.
Yeah.
Transverse process of cervical vertebrae and mastoid process of temporal bone.
Yeah. Yeah. Okay. Wow. So I hope the most common word you heard her say there was transverse process. Transverse process of upper 5 thoracic, transverse process of thoracic vertebrae, transverse process of cervical vertebrae, yada, yada, yada. Essentially, this muscle attaches to the transverse processes, which kind of explains why it's a little more lateral, right? The spinalis is attached to the spinous processes. These things sticking outside here are the transverse processes, and it likes to grab onto them. And by the way, the same thing happens. When it grabs on here and it squeezes, you get an extension. So it can work with that too. By the way, when you squeeze one side, you get lateral flexions. Yay. Okay. And it does attach, there is one important point. It attaches to the transverse processes, right? All the way down, essentially. I'll explain that in a second. But it goes all the way up to the head, and it attaches to something called the mastoid process of the temporal bone. And it's right about here. So, it does this. And it too kind of disappears into the thoracolumbar aponeuroses. We'll explain that in a second. It does this. Now, boom. Hold on. Okay. This is a human skull, not a real one. Hi, everybody. This in orange is your temporal bone. I'm just pausing to make sure what I'm telling you is going to stay true. If I had to pick the most important bone on the skull to a massage therapist, it's probably the temporal bone. It has lots of features that I care about that affect people. All right? For one thing, the jaw joint itself actually hooks into the temporal bone. The mandible, this is called the mandible, hooks into the temporal bone. The mandible hooks in the temporal bone, or the temporal bone hooks into the mandible. What do you suppose you call your jaw joint? Anybody remember what I said?
Mandible.
Well, that's my jaw bone. What do I call my jaw joint? Where the
Temporal mandibular joint.
temporal mandibular joint. That's where TMJ comes from. And I just broke our jaw. Okay. That's where TMJ comes from, though, is temporal mandibular joint. When people have problems with the temporal mandibular joint, this is kind of where they get problems from. Sorry, guys, I'm trying to fix the... Okay, there we go. Wow, I'm a surgeon today. Okay. So, whoa. That is one feature that I really care about, the temporal mandibular joint. I'm not expecting you to remember all this. This is coming attractions, but I want to explain why the longissimus is important. So the temporal, the temporalis, this bone here, the temporal bone, contains the jaw joint. That's one reason I really care about it. It also has a hole in it. Anybody want to guess what this hole is for? It's called the external auditory meatus, by the way, but anybody want to guess what that hole's for?
Your ear?
It's your ear hole. Yeah. Put your finger in your ear right now. You're sticking it in your temporal bone. In fact, stick your finger in your ear right now and move your jaw, and you will feel your jaw joint inside your ear. That's you touching the back side of your jaw joint, your temporal mandibular joint. So that's two features that I think are pretty interesting. There's also a little toothpicky thing under here that you probably can't even see on the screen. A little toothpicky thing sticking out here called the styloid process that actually hooks to a muscle that hooks to your throat and actually hooks to your hyoid bone later that we're going to learn about. That helps you articulate and talk and move your tongue and all sorts of stuff. But here's a very interesting point. It's got a bump back here. You can feel it in the back of your head. On both sides, you've kind of got these bumps here. This is the mastoid process of the temporal bone. This is where the longissimus attaches to. Now, you know that your teacher is obsessed with places where lots of muscles can be found. I call those high priority targets. The last one I talked about was underneath the armpit here, because I was obsessed, right, about the fact that the latissimus dorsi ran across that area, and thus the teres major ran across that area, and the infraspinatus ran across that area, and thus the teres minor ran across that area, and the rear delts ran across that area, and the long head of the triceps ran across that area. So I was obsessed with it, right? I'm like, you got to rub that area. There's 6 things there, right? If you go on a trip and there's 6 sites to see with getting off at one place, you're going to go there. Yeah? Just nod. Say yes. You understand the brilliance. Good. The mastoid process actually has lots and lots of pressure on it. We're going to later learn about other muscles that attach here. This is another high priority target. There are actually 4 muscles that attach to the mastoid process. Today we're learning about the longissimus. The longissimus actually attaches back here. So that means the whole head and spine can be pulled back from the longissimus, but it also means the head kind of pulls against the back too. So anyway, the longissimus attaches to the mastoid process of the temporal bone and the transverse processes of the back. Now,
Question.
oh, go ahead. Ask your question. Go ahead. Okay, really quickly. They mentioned something called the thoracic tendon, common thoracic tendon. They just mean kind of this thoracolumbar aponeurosis again down here turns into a tendon. But it all hooks to the transverse processes. So spinalis is on spinous processes, longissimus is on transverse processes, all the way up though to your mastoid process. Yes, what's your question?
So if somebody came in with neck pain, oh, it hurts when I turn my neck this way, could be traps, could be, it's not scalings, what's the one we just learned, levator,
Yep.
or could be longissimus then, correct? Because it's still hooking on to that.
Miss Monreal, I thought you said you weren't going to be asking lots of questions today because you were tired. You weren't going to be insightful today.
Fine, I'm going to sleep.
I mean, you made a promise. Nothing upsets me more as a teacher than when you apply what I'm teaching you and process it and truly learn it and then apply it to massage therapy. Yes, that's damn brilliance. Yes, exactly right. If somebody comes in with a neck problem, it can most definitely be the longissimus and it can be hooked all the way to their butt. And I know butt is not the correct term to use, but I'm trying to emphasize something, right? Your head is connected to your butt. Yes, absolutely, the longissimus could cause neck problems, and back problems could be neck problems could be back problems. And honestly, if somebody has a neck problem, you should probably at least work down to their back. And yes, very much so. You nailed it. Thank you. Okay, this is doing pretty good for a sleepy person. I love it. Okay, so simply put, the spinalis is most medial. It attaches to the spinous processes of the vertebrae. Next out laterally is the longissimus, and it attaches to the transverse processes. But what's interesting about the longissimus is it goes all the way up to the head and gets to this mastoid process. By the way, the spinalis gets all the way up to the head too through the ligamentum nuchae. But anyway, it attaches to the mastoid process. So both these muscles actually attach to the head. One goes down the spinous process, the other one goes down the transverse processes. Does that make sense? Let's ask people I can't see if it makes sense. Miss Torres.
Yes.
Which spinal erector muscle, erector spinae muscle, attaches to the spinous processes of the vertebrae?
Spinalis.
Thank you.
Spinalis?
Yep. Which one attaches to the mastoid process of the temporal bone and also the transverse processes of the vertebrae?
Longissimus.
Yes, thank you very much. Cool. Miss Harper. Miss Harper,
Yes, sir.
which erector spinae group muscle attaches to the mastoid process of the temporal bone?
It's the longissimus.
Cool. Thank you. That's it. Miss Felix Osuna. Which erector spinae muscle attaches to the ligamentum nuchae and all the spinous processes in the back, essentially?
Is it the longissimus?
It attaches to all the spinous processes in the back.
all those spinalis.
Yeah. And I threw in ligamentum nuchae because that's true too, but ligamentum nuchae attaches to the spinous processes. It's right in the middle too. All right, everybody? Cool. Good job. Awesome. Let's move right along. Let's talk about the iliocostalis. Okay. What are the origins for the iliocostalis? What are the origins for the iliocostalis? Miss Bolotic.
The origins are the common tendon
Yeah.
and the posterior surface of ribs 1 through 12.
Yeah. So don't worry about the common tendon again. As far as I'm concerned, that's part of the thoracolumbar aponeuroses. It's down here. But she said the posterior, which just means the back sides, are ribs 1 through 12, right? So how many ribs do we have, Miss Bolotic?
Like 24, I think,
Yes. How many do you have on each side?
on each side, 12.
Yes. So basically what Miss Bolotic just told us is this muscle attaches to all of your ribs. She said ribs 1 through 12, and we only got 12, so it attaches to all of my ribs, right? And if we look at the insertions, it attaches the transverse processes of the lumbar vertebrae, and then really all the ribs. So how high up does it go? And then I think transverse process of lower cervix. So this thing kind of comes out in a big swooping thing. It hooks to the transverse process of the cervical, goes out to the ribs, and comes back in at the lumbar. Kind of like that. Transverse processes of the neck, all the ribs, and back to the transverse process of the lumbar. Can we see how this would help you cause an extension of your back? Can we see how if these muscles start to pull, I'm going to get this powerful backward pull? Yes. Yes? Good. Miss Cooper, what is the main action of the erector spinae group if they are working bilaterally?
But to pull backwards or retract.
You are essentially right, but I want you to use the right word. What is bending behind you? Not bending in front.
What, anterior?
So, what am I doing now?
What is that? You're going forward.
Yes, what do we call this? What do we call when I bend in front? When I bend in front. What am I doing here? What am I doing here?
You're flexing.
Okay. What do I call when I bend back?
Extending.
Cool. So what was the main action of the erector spinae group?
Extend.
Thank you. Awesome. That was good. Yeah, don't worry. I'm just trying to drill it into you. They extend the back when they're working bilaterally. Miss Hanson, what happens if they're working unilaterally?
Flexion?
Yeah, what kind of flexion?
Side flexion?
Side flexion. And when things are going out to my side in the medical world, what do we call this? It's not medial.
Say it again, it's not what?
It's not medial. It's the opposite of medial. Lateral? Lateral.
Extension?
Lateral flexion? Yeah, lateral flexion. Cool. Lateral flexion to either side. Cool. So bilaterally extends, laterally flexes. That's what they do. And we can kind of see that, right? If I pull one side, it's going to pull the skeleton this way. Pull the other side, it's going to pull the skeleton. Pull both sides, it's going to pull the skeleton back. Yeah? Cool. All right. That's the erector spinae group. Talk to me.
About to make your day.
Yeah?
I have another question.
I love it. Hit me.
Okay, so since we have layers of muscles, when one is being compromised, you said it is being starved of blood and nutrition, correct?
Yeah.
It's safe to assume that the surrounding muscles also are compromised. Do they get kind of glued together? Like, I mean, each one's have their separate little, I'm thinking of a piece of chicken,
Yeah.
like their different little pulpy thing.
Yeah.
When there's that restriction, do they get stuck that way?
Yeah, they do. Now, by the way, I'm not a biologist. I don't fully understand this, but yes, we think that definitely happens. We think there's a number of things that happen. So, really, there's a whole lot of little fibers there, you're right. And it might be just a few fibers that are starved for blood because they're cut off for some reason. It might be lots of fibers. We don't know. It depends on what the problem is that caused it. But you're right, that blood is also kind of cleaning things out. This is where people talk about toxins. It's not really toxins, but those areas can get stuck together and glued together, absolutely, for various reasons. One is they could be kind of dried out because they're not getting enough blood and things like that. That's a problem. They might have waste material building up so that the tissue is actually sticking together. And that's one of the reasons we do skin rolling, is just to lift the tissue off and then blood gets back in. So that would cause a problem. And the other thing is they could be stuck in a contraction, which is a totally different scenario, but can also keep blood from getting in, where the muscle's gotten a charge to fire, and it's not unfiring for some reason. It's kind of clamping down and trying to hold itself tight, sometimes to protect from an injury that may no longer be present. Sometimes there's a nerve pinch that's actually causing the muscle to tighten up out of pain, and that can stop blood flow too because it's clamped down. All that stuff can, but you're right. Then the area gets gummy, sticky, stagnant, and then blood doesn't get in there very well. And one of the things we're often doing is just trying to get blood back into that area. Yeah.
I just try to picture what's going on.
Yeah, I want you to visually try to picture.
So is that when you have like knots?
Yeah.
Big, like bumpy or like weird knots that you just have to work through them to get that blood flow?
Yeah, pretty much. I mean, by the way, you guys are talking about the most talked about subject in massage therapy right now, which is what is the cause of knots and how do you alleviate them? And there's a lot of argument about this, and I honestly don't know the exact right answer, but essentially, yes, I suspect they come from lots of different things depending on what the situation is. But knots can be a part of a muscle caught in a contraction. So just like my bicep is contracting, a tiny piece of it, remember it's made up of a whole bunch of fibers, a tiny piece can be caught in a contraction, and that could be a knot. It could be some stuff is glued up in there, right? There's just not getting blood flow for some reason, and that's kind of making it feel like a knot. There could be some scar tissue in there. All sorts of stuff could be a knot. And in general, rubbing and stretching that area out seems to help release it from that problem, either by getting blood flow in or by unpinching the nerve, one of those two things.
So basically you're saying there's no way of really knowing exactly why, but there are different things that would contribute?
Yes. Yes, and it's a bit of a cop-out, by the way, on my part, but I think I'm telling you the most truthful thing to tell you. I think if you had some...
I don't think it's a cop-out, and I do know that it's a controversial
that's
thing,
why I'm doing it.
Causes it, and you know.
And everybody's so sure. Every time I talk to them, they're like, well, that's a trigger point. Trigger points are caused by blah, blah, blah. And then you read the research, and it's like, I don't know if that's true. And then somebody else comes along and goes, well, it's caught in a contraction, or that's debris in there, or whatever. And I'm like, the fact is we do know that there's poor blood flow in the area, and quite often a pinched nerve.
And pretty much we know that if you rub it and increase the blood flow, you're going to help it relax. You're going to help it all together, correct?
Almost 100% for sure, rubbing that area is going to help it because it's got a blood flow issue. The only thing you might add to the statement you just made, so I'd rub it all the time, basically, right? For knots, constrictions, all the stuff we're talking about, rub that. The only thing I would add to that is it's possible that a nerve is being pinched that feeds that. The nerve could be actually pinched inside it, and so rubbing it just takes care of the whole problem. But the nerve could be coming from somewhere else, right? So this could be in my arm, and I'm going to rub the spot no matter what because the spot is lacking blood and there's a problem there. But there also might be a pinched nerve in the neck, so rubbing the neck could actually help this problem too. That's the only part I would add to that.
And sometimes when you only work that one area, it can make another area worse if that hasn't been cleared up. Is that correct?
If you, it would make it.
So if the restriction is actually somewhere else, but you're working, let's just say I just went to someone and I'm just working that one area. If you haven't cleared everything else, that clog or whatever is still going to be right there where it was originating from. Is that correct?
It's going to come back. If that was not the problem, but it was the symptom, they will feel better temporarily because you've relieved the symptom. But if the nerve is still pinched to the neck in this very simple example we're using, they're going to leave and that problem is going to come back, yes. They're going to say, I really feel great for like 24 hours after your massage, but then it kind of came back. Now, by the way, guys, you could do everything right and it could still come back because this person's doing something weird with their neck. Who knows? But the point is, yes, we're trying to get them longer relief. And by the way, since you brought it up, it's such a good question. And it's really where we're headed with the entire program. This is why we're studying anatomy. We're studying anatomy for this reason. For this reason. Hold on, let me grab some tape here. I feel like this is a tape appropriate moment. Okay. So, let's take, actually let me do this too, but anyway. All right. This is how I want you to think as a massage therapist. That's why I'm spending time on this. Let's suppose for whatever reason we're not quite sure you've got a muscle caught in a contraction right here in your longissimus. And as a massage therapist, you can feel it. You come up here and there's a knot there, what we call a knot. And it really seems like it's longissimus. You kind of come along and like, bump, there's a knot. Now, a good massage therapist, don't forget, there are other things. You could have run across the rhomboids and just be clicking across them and think you're feeling a knot in the spinalis. But I'm supposing that you've ruled that out and we really have a knot in the longissimus here. Okay? Doesn't matter what muscle, but we got a knot here. That knot is tight. And blood is not getting in there, and blood is actually one of the things that will help loosen it up. So yes, rubbing this out and stretching this out helps loosen it up. Then, to be extra safe, you know that there is a nerve that feeds this that goes into the spine. It goes over the spine, and it goes up the spine, and actually goes up in the head. So I'd definitely be massaging this nerve here too to make sure that it's not a pinched nerve here that's causing a problem. Okay? That would be my second thing. But then, if we want to go to the third level, this area can be tight back here because something in front is pulling against it. That's a structural look. So the back could be tight and maybe that one knot's there because the back's working really hard. It's starting to get some problems because maybe, where you haven't learned about this muscle yet, but maybe the rectus abdominis is pulling too hard in the front. You know? Or maybe the head's just stooped over on a computer too long and that's causing the weight of the head is actually pulling on the longissimus and causing problems down here. But my point is, we're kind of looking at three things. Locally, just the knot. In general, unless there's something broken there, you should always be rubbing this spot. It's causing them pain, it's bothering them. Any massage therapist should rub this. Many massage therapists stop at that point. If they can even find this, by the way. You should also look for a nerve connection to the spine. So loosen up the spine in this area. And then you might want to look for structural problems like what's going on with this longissimus here? Is there pressure on it in front? Is there something that is maybe pulling the head forward because the longissimus hooks here? And forget about the rectus abdominis. Let me tell you a really obvious one. I just didn't want to get to it today because I was worried about throwing too much at you, but it's so sad. Anybody heard of a muscle called the sternocleidomastoid?
Yes.
Sternum, clavicle, mastoid process. Can you see the orange muscle and the yellow muscle? Longissimus, sternocleidomastoid. They literally tent off your head. Your head is the tent pole that actually helps support them. And they can literally fight for your head. And so I'd be checking this out too. So that's where you get into structural anatomy that most massage therapists don't really do.
Are we gonna get into that more?
Yeah, I mean, we're in the first class and we're already getting into it. You know what I mean? But you have to have some anatomy to talk about it, right? So you have to understand, if you don't understand the actions, you don't know what could be fighting against the actions. Right? So that's kind of why we have to learn the muscles, and that's why we're having this discussion today, because we now have some knowledge to work off of. And we've already been talking about it. We talked about how the rhomboids could argue with what in front that goes around the ribs.
Serratus.
Thank you. 100% true. So we're already talking about, you're probably going to find a knot in the rhomboids, in lots of people, but you're going to work that out. But then you're going to think, well, I'm going to work on the spine too, because maybe the rhomboids are pinched from the spine, but also I'm going to work the serratus anterior and pec minor, because those can fight with the rhomboids. So now you've kind of hit three things. You've hit the knot, you've hit a nerve that could be affecting the knot, and you've hit the muscle that could be fighting with it for structural dominance to try to keep this person in good posture. Yep.
Thank you.
Yep. And there is one other thing that kind of ties into all that we'll talk about, which is just what's called fascial lines. That this could be part of a big, long structural chain, and we might look at the entire fascial line. We're not quite there yet, but we will be getting into that. It's what we touched on in maternity massage, just talking about a fascial line, where you've got this whole chain of muscles. And so a problem in the neck really can sometimes be tied all the way down to a problem in the foot. And that's not crazy thinking. And so it's not
I have a question.
Yeah, go ahead, please.
Okay, so you know how that iliac costalis attaches to the thoracolumbar?
Thoracolumbar aponeurosis, yeah.
Yes. So that is fascia, right? That is
Yes.
the tendon?
Yes, it's a
Okay.
sheet-like tendon.
Okay. So back to the knot thing. Can you get one, or can you get knots right there, and do they work the same as a muscle?
Kind of. So you bring up a really fascinating point that when I actually went to massage school, nobody knew about. And really just in the last 10 years, they've started talking about this. Strict muscle problems, when it's just muscle, are really easy to work on. Muscle is highly vascular. It gets a lot of blood to it, and it's very receptive. And if you rub muscle in general, it gets better very quickly. But usually people don't just have muscular problems. They've got fascial problems. So what happens is, if I have overtaxed my body, like if I stay like this for a while working at a computer, these muscles here are not strong enough to hold up my head for 8 hours a day. Can't be done. So what happens is my body actually starts to tighten down the fascia and thicken it and lock it down to help support this strange position that I'm in, because it's trying to do the best to serve me. And the same thing could be true in your lower back. And so the fascia can thicken up there, get sticky there, kind of maybe not form knots there, but form areas of congestion, areas where it's too thick and too stuck, and pinch on nerves too. And there is nerves in fascia. And so yes, and fascia is a little slower to respond because it's not quite as vascular as muscle is, but fascia is definitely something you'd want to work on. And I would treat the thoracolumbar aponeuroses as though it was a giant muscle. I would rub it too.
So
Try to
if
open it
somebody
up.
felt a knot there on somebody, it might not necessarily be the fascia, but maybe the muscle underneath?
Yeah.
Or would it be the fascia?
Yes.
Okay.
Here's why, by the way. Here's why I'm saying that. The book is trying to teach you this stuff, so it's like thoracolumbar aponeuroses, muscle underneath. That's not how it is when you dissect a human being. It looks like this down there. They weave into each other. It's this darn spider web thing again. The fascia weaves into the hips, and the muscle really weaves in, and it's not like you can all of a sudden tell. It's like crossing state lines and there's no sign up. You're like, are we in Colorado now all of a sudden? It's getting greener, but I don't know when we crossed over, right? So it's a gradual thing, and it weaves in there, and it'd be very hard to tell, and there is muscle woven into fascia. And remember, muscle has fascia in it, right? So
Yeah, thank you for those explanations because I'm just really big on trying to picture. So when you explain things like that, it's just a reminder. Because I know you said that before, but now when you say it again, that it's not just necessarily just laying on top of each other.
Yeah.
I need to remember that.
It'd be more like textiles or knitting. Like everything in your body is knitted into other stuff, including the bone. You know, we think we just kind of attach on the bone, but it's knitted in there.
Oh, I like that.
It's on page 187, like the picture, so you guys can know kind of what we're talking about.
187, let me see.
189, my bad.
Let's see if I've got it in my thing. Yeah, kind of. Well,
yeah,
and 188 shows you the thing.
Like, I know how that's pictured. I have to picture like how it's going in the body so that I can then come up with a game plan, I guess.
Yeah, no, I want you to three-dimensionally picture this stuff. That's the goal. And Ms. Torres is right that that's a pretty good picture, but please listen to what I'm about to say. That picture is an unintentional lie. And here's what I mean by that. If you go to a cadaver lab, they will tell you they scraped off all this fascia to try to show off the muscles. What happened was, a long time ago, we figured out that you have contractile tissue in your body, and we got fascinated with it because it makes you do stuff like this. And we're like, well, of course we care about what makes people move. And we assumed all the fascia was just other junk in there, really. And they dissected up the body very carefully to show these muscles. But it's kind of like showing you a road map of Arizona and saying this is Arizona. No, it's not Arizona. It's a map of the roads of Arizona. You're not showing me the desert landscape. You're not showing me any of the other stuff around there. And the dirt roads and the desert landscape weave into one another. So you're giving me a very false picture. If you cut a person open, don't do this at home, folks. If you cut a person open, you would have an extremely hard time finding these muscles until you were right on top of them, because they do not cleanly weave into one. They weave into one another. That thoracolumbar aponeurosis is not like it is in the picture. It is in that general area, they're right, and eventually those borders kind of show themselves, but it's never clean like that. You can't do it. And so, yes, I want you to be thinking about the way you're thinking about it, Ms. Monreal, which is things are woven into one another. It's almost more like you're in territories. Like, I'm now down in the thoracolumbar territory where all the spinal erectors start to weave in. It's very hard, yeah. And if you feel somebody's back today, when you think about it, you'll kind of feel that. You're feeling layers and layers and layers of interwoven sheets of tissue and such.
But for educational purposes, this is the way we have to learn it because we have to know the distinctions, correct?
Exactly. Exactly. What we normally do is, normally I don't get these questions at this point in the course. And normally I teach you the anatomy first, everybody. And then later I pop it on you that it's been a lie. And that of course these muscles really exist, but you'll never find them this perfectly like this. And they're woven into the fascia. We start to introduce fascia to you. And then we start to introduce fascial chains to you. And we start to build up on that. But you guys have been asking very intriguing questions to begin with. And you're able to digest the material and put it together. So we're starting to introduce higher concepts to you. Yes. And the muscles really are there. I don't mean it's a lie in that sense. I mean, they're not that cleanly there. Just like if you go to the grocery store today and buy a steak, a lamb chop or whatever, go try to find that in an actual lamb or a cow. Go try to find the loin. Go try to find the rump roast. A butcher for years and years and years has decided we were going to cut the cow's butt or the cow's ribs or the cow's whatever, this exact way to give you this cut of meat. But the cut of meat wasn't there to be found. They've chosen to divide it up that way, and now we say, well, that's a loin, that's a whatever. We've kind of done that with the human body, if that makes sense. I hope. Okay. Any other questions? Thoughts? Yeah? How about I release all of your homework right now so that maybe you can do it and have a nice weekend and not even have to deal with that?